Welcome to NASTAD's 2021 National HIV and Hepatitis TA meeting. I'm Isaiah Webster, Director of Capacity Building Assistance for NASTAD. Our opening plenary today focuses broadly on equity, and it'll take place in two parts. First, we're going to have a conversation about NASTAD's commitment to Black lives, and second, a panel discussion on telehealth. This first section really does pick up on where we left off last year. If you attended the 2020 TA meeting, you know that we focused on centering Black lives. And so today we wanted to start there and let you know about the progress we've made in the last 12 months. I'm going to introduce our first two speakers. First, you'll hear from Dr. Jennifer Lee. She is Director of the Bureau of Tobacco Control for the New York State Department of Health. Prior to her current role, Dr. Jennifer Lee oversaw special projects for the Center of Equity, for the Center of Quality Improvement and Innovation at the Health Department's AIDS Institute. Dr. Jennifer Lee is dedicated to making an impact on the world by addressing health inequities and health injustices in diverse communities through the lens of resiliency, community empowerment, advocacy and social justice movements, human rights, community-based participatory research, and a strengths-based approach. Her research and work provide unique pathways for individuals and communities to make changes through explicit aims at social and political change. She is a NASTAD Minority Leadership Fellow from the 2018-19 cohort, a space rooted in social justice for health department staff of color to engage in critical conversations regarding intersectional systems of oppression, structural processes, and intersectional causes of health inequities that impact sexual and gender expansive people and communities of color. Jennifer holds an MPH and a PhD from the SUNY School of Public Health and Health Policy. Dr. Jennifer Lee is also the first recipient of the Dr. Adweli Troutman Health, Equity, and Social Justice Scholars Award, demonstrating her commitment and dedication to the principles of health equity, social justice, human rights, community activism, and national and global health. I also want to introduce to you Dr. Stephen Lee. He is the Executive Director of NASTAD. Prior to joining NASTAD, Stephen was a global health expert for the Elizabeth Glaser Pediatric AIDS Foundation, where for 13 years he managed the development and implementation of programs that provided prevention, care, and treatment services to individuals affected by HIV. He has a bachelor's degree in biology from Baylor University, a degree in medicine from Emory University, and an MBA from Heroic University, and a postgraduate diploma in Health Systems Management from the University of London School of Hygiene and Tropical Medicine. I should let you know that Dr. Stephen Lee and Dr. Jennifer Lee are not related, and I resisted the urge to name this session something along those lines. Jennifer, I'm going to turn it over to you to get us started.
Thank you, Isaiah. So good day to all. I am so excited and honored to welcome all of you to this virtual meeting and having a one-to-one with Dr. Stephen Lee. But as I was getting ready this morning, I was trying to figure out, what I was going to say and what I want to wear. And I came across this t-shirt and it says, "Public health is social justice." And, sweatshirt wear is not usually, conference meeting wear, but I thought it really resonated with the message and the meeting that you'll be, experiencing over the next few days. So I really wanted to represent that and show that today. So ending epidemics means we need a social justice and human rights lens in our work. And if social justice means that everyone deserves equal rights and opportunities, this includes the right to good health, or what I would say, health as a human right. Yet today there are inequities in health that are avoidable, unnecessary, and unjust. And these inequities are the result of policies and practices that create unequal distribution of money, power, and resources among communities based on race, class, gender, sexual orientation, place, and many other factors. And to assure that everyone has the opportunity to attain their highest level of health, we must address the social and structural determinants of health and equity. And the principle really underlying a commitment to ending epidemics means health equity, centering lived and embodied experiences of our communities, and innovation. And social justice is so is social justice in health. I'm sorry. And with that, I would like to introduce our fierce leader and someone I'll have an awesome dialogue with today. As Isaiah mentioned, just when you thought you had one Lee, you got two of them today. We both share the love for NASTAD's work, and I just want to say hello to our Executive Director of NASTAD, Stephen Lee. So hi, Stephen.
Hello, hello, hello. Good
Hello.
morning.
Good morning, good afternoon, depending on where you are in this world today. So Stephen, this meeting normally opens with a welcome message from you. And in that spirit, what would you like to say to all the participants as we begin these few days of sharing and learning from one another?
Yeah. Well, first of all, thank you, Dr. Lee. Thank you, Jennifer. Thank you, Isaiah, for that very warm introduction. And good morning and good afternoon, everyone. Very heartfelt and warm welcome to all of our participants for this meeting. We have approximately 600 people who are registered. I can't see how many people are actually joining right now, but this is very much comparable to our meeting last year, virtual meeting last year, where we also had 600, I think maybe 650 or 700 people registered. So it's great to see that people taking advantage of this virtual platform to join the meeting. We're looking forward to a very robust, very productive set of conversations and networking opportunities, really for the opportunity for us to advance the work that all of you in our health departments and jurisdictions are doing. Beside our member participants, we also have federal partners who are joining this afternoon, and we want to welcome them. They will be joining for select breakout sessions and observing some sessions. We want to thank them for joining and also thank them for their ongoing partnership with us as we work to end the HIV, the epidemics of HIV, hepatitis, and STI. And then finally, I do want to thank our sponsors, Dynavax Technologies, Gilead Sciences, Script Guide RX, Janssen Infectious Diseases and Vaccines, Magellan RX Management, Theratechnologies, Inc., Aviv Healthcare, and Walgreens. They have been really strong partners and supporters of this NASTAD in the past, but especially for this meeting as well. So please be sure to visit the sponsors lab on the meeting platform and to view resources and other videos and resources that's available from our sponsors.
Thank you. All right, we can't do this work without partnerships, and I really agree to visit and take advantage of getting to know them better and figure out better ways to collaborate with one another. All right, so my first kind of segment of questions for you, Stephen, relate to this meeting. And the theme is integrating equity, experience, and innovation to end epidemics. So would you mind talking about how this theme really relates to NASDAD's current work?
Yeah, for sure. Happy to. So this meeting really started as the ADAP meeting for, early in the days of NASTAD's existence and supporting HIV and AIDS directors. And as many of you know, in the past 3 or 4 years, we've really incorporated and integrated not only the ADAP meeting, but also our prevention care meeting, prevention and HIV care treat meeting, and also our hepatitis meeting. So we truly have an integrated meeting that builds upon what's already happening at health departments. Many of our health departments are doing great work to ensure health equity, to leverage experiences, to share innovative techniques. And we really want to build on that to help end the intersecting epidemics or this endemic of hepatitis, HIV, STIs. And we also want to make sure that we're ensuring that we're engaging on improving the health of people who inject drugs. This meeting, and really kudos to Isaiah in organizing the meeting, Isaiah and team in organizing the meeting. These sessions, breakout sessions, will really build upon the 4 pillars of NASTAD that's been articulated through our strategic plan process over the past year. Those pillars are health systems, program integration, health and racial equity and organizational excellence. So I'm really especially looking forward to the applicability and learning from these sessions in terms of how we can build upon and learn from what's happening in our jurisdictions to move NASTAD forward in achieving our mission and our vision.
Thank you so much. Do you mind if I get a little personal?
Maybe, it depends.
Okay. And it won't be too deep. I just, I realize you've been a part of NASDAD's work, or it'll be 2 years in February of 2022. And so congratulations for that. But you've been in your position during quite a time. And so while I know it's only been, 22 months, do you have a favorite moment or what stands out in your work thus far? And, kind of some of the lessons you've learned over this time. And then I'll ask you the more personal question after.
No, yeah, you're absolutely right. I started in February 2020, February 3rd to be exact, 2020. And literally a month later is when all heck broke loose and the world essentially shut down due to the coronavirus pandemic. What really stands out for me over the year or 22 months is the resilience and steadfast commitment of NASTAD staff and you are members or public health champions. I think NASTAD staff really continued to provide high quality technical assistance and really pivoted from an approach of traveling to provide technical assistance and capacity building efforts to a virtual approach of providing that support. And I think maintain the quality of our work through this virtual platform or virtual mechanisms. And then you, our members as public health champions, really continue to serve your communities. And I really want to recognize and appreciate the sacrifices that you and your peers continue to make. And that truly has stood out for me in terms of the kind of observations over the past 22 months.
Yeah, absolutely. And I think if anything, we kicked it into another gear, if that's even possible, just to collectively put effort toward another intersecting pandemic on top of all the other epidemics that we were responding to. And so I know in a lot of your public comments, you've often spoken about the toll of the incredible times that we were living in, from political upheaval, social unrest to COVID. So this is my personal question from you around how did you take care of yourself during this time, or what does self-care look like for you?
Actually, okay. Let's see. I would probably have to admit that I probably didn't do as great a job of taking care of myself as I should have. So I'll own that. And members of my team will probably reinforce that. They're encouraging me to take some time off. But I do a few things that I've done. So I started doing during the pandemic. One was I'd not done meditation before, and in the past year and a half, I've started and ended my day with 15 to 30 minutes of meditation, really as an opportunity to center myself and kind of reinforce the positives for the day, positive to start the day and the positives to end the day. I started exercising much more regularly. So I try to do something at least 30 minutes, 5 to 6 times a week, days a week. And then I started cooking at home. At the beginning of the pandemic, I noticed that when I looked at my Uber Eats receipts, I noticed that there was a lot of Five Guys burgers and fries, and I decided I cannot go through the pandemic eating Five Guys burgers and fries. And so I started learning to cook Chinese food. Actually, I have my ethnic heritage is Chinese, and so I started learning how to cook Chinese food at home.
Wow, those are some good little tips that you took to, or measures that you took to take care of yourself. And Yeah, I completely agree that we might have taken for granted all the delivery of services and things, but I think centering yourself through meditation and cooking is awesome, and finding those roots back to our cultural heritage and our ancestors. That is beautiful. Um, okay, so let's see. Do you have any like major lessons learned through this time that really influences your decision making that other, everyone attending today could carry with them through the next few days and beyond?
Yeah, that's a great question. And I'd mention two things. One is that I've learned and appreciated to really center my values, whether it's personal values and organizational values in decision making. I take my personal integrity and my personal values very, very seriously, and I think I've tried to apply that in decisions that I make or that we make as a leadership team at NASTAD. I will admit we may not get it right every time in terms of the decisions or the decision-making process, but I will say that I and the team really work to center our personal and organizational values as we make decisions. So that's one of the things that I've learned in this new leadership role, is to really ensure that your decisions are based on values and personal integrity. And the second thing I would mention is really, beside the pandemic, as everybody knows, the other big upheaval that we had over the past year and a half was the George Floyd and Black Lives Matter resurgence of Black Lives Matters as an important movement for the country. And in leaning into the Black Lives Matters movement, I really appreciated the need for diverse voices in making decisions. And I think we've also tried to ensure that we're not just engaging and ensuring that racial and ethnic voices are part of this discussion and the decisions, but we're also leveraging experiences, whether it's professional, lived, educational, all various forms of experiences are welcome to the table in our thinking, in our design of policies and procedures and decisions.
I love that. And I think there is so much infinite worth and value in centering those experiences and ensuring that they're really infused and immersed in our work. So thank you so much for that. Related to kind of what you're already talking about, which is anti-racism work, last year's technical assistance meeting had the theme of centering Black lives to end epidemics. And if you had to kind of assess the progress NASDAD has made in the last 12 months in upholding that theme and all the other things you had just mentioned, how would you define it?
Yeah. That's also another great question. And so as I reflect, I would say we've made some good inroads, starting with our board. The board of directors as an entity has really embarked and embraced on moving forward in our racial equity and health equity, as evidenced by a subcommittee, the Board Anti-Racism in Public Health Subcommittee that was formed, I think officially 3 months or so ago. The NASTAD staff has also formed an anti-racism work group, and that group has been meeting and working for the past year or so. We've also engaged a consultant group, Health Justice, to work with us in both developing trainings for board and staff, and ultimately helping us to operationalize our health equity and racial equity work that hope will ultimately impact members and jurisdictions. And both the board committee and the NASTAD work group have identified priorities that really span, I would say, four major categories: our governance, our governance structure and examining those structures to see how and where we can infuse equity into our structures, the organizational structure as well, and culture, and ensuring that we are living those values in our organizational culture and structure and culture. Looking at our operations processes and our program processes. So each of those have various key things that we're doing to address those four broad areas. And then the final thing that I would mention is that we're really, as part of the culture, we're really trying to embed health equity and racial equity into the fabric of the organization. And as I mentioned earlier, one of the key pillars, one of the key priorities that has emerged from our strategic planning process is racial equity and health equity. And so if we plan to achieve our mission and our vision, we will have to ensure that we're engaging on and building on the fabric of racial equity and health equity.
Wow, I love that you talked about anti-racism work, really operating in these multiple layers or levels of from the board to staff, and then of course that will trickle to the technical assistance that you also offer to health departments. And I think that is a really important and vital strategy in how we can operationalize health equity from a system standpoint, but also ensuring that it's, really infused throughout all steps of the process. So that's great. And I think related to some of the, technical assistance that, I as a member or someone who's gone through the minority leadership program of NASTAD and being an alum, I really understand firsthand about NASTAD's TA to health departments. So I think beyond that is, what role of the health department staff, what's the role of health department staff when it comes to helping NASTAD help them?
Yeah, that's another really important question. And I would say there are probably two things I would mention. One is just sharing their wisdom. Our MLP program and our leadership program and our learning collaboratives and our communities of practice are among our best technical assistance tools. And so working with and implementing those tools and MLP program are one thing I would mention. And the second thing I would mention is to then, once we have got strong individuals like yourself who've gone through the program, is to really offer opportunities for individuals to practice what they've learned, practice the skills that they've developed, and to stretch and to grow. For example, making individual or MLP alums part of any working groups or leading working groups, department working groups is one example. At NASTAD, currently, one of the things that we're doing is we are actively recruiting MLP alums to be part of the board subcommittees. One of the things that we're committed to at the board level is to ensure that there is participation across the spectrum of members, not just board members, but and members, but then also other health department staff who can participate in these board subcommittees. And we've been very active in recruiting MLP alumni to participate in those committees, really as an opportunity for them to practice their leadership skills and capacities gained through the MLP program.
Thank you, Stephen. And yeah, I'm so proud that I think that was one of the best experiences of my life, if not one of the, the best. And so I know I've been kind of putting you on the hot seat and asking you a lot of things, and I wasn't sure if you wanted to, I'm nervous, what questions you might have for me, but I'm open to also talking about that experience or just, you putting me on the spot.
Yeah, no, thank you. Actually, I do want to probe a little bit with you. I'm a quality improvement kind of guy, right? And so one of the things is always trying to learn from our experiences. And so as someone who's been through our program, the MLP program, what are your thoughts in terms of how to take the program to the next level in the next 3 to 5 years? What are your thoughts in terms of how we move the program forward to the next level?
Sure. I think that if we, again, this MLP program is just so special, and being rooted in a social justice frame, it really helped me understand my role in this larger public health work, and better committed myself to those values to infuse that in my work and be unapologetic about it. And so I wish we could give more health department staff of color specifically the opportunity to have that time to visualize that, to share our experiences and stories, to learn from each other, and really understand our power and our leadership in ending health inequities. That was really invaluable for me to understand, and be in space and physical proximity with folks who not only have experienced the microaggressions or the things that I have also been through, but some of the lessons or teachings that came from MLP was really about how we step in our power, and how we utilize our lived experiences to inform our work. And the intersections of our lives and those stories can transform systems, organizational culture, and really end epidemics. Like, I really do believe that. And with these personal connections too, that last a lifetime, like, I'm forever grateful. And I wish that, we could really have more people have that experience together, and, be part of a program that has changed my life. And, I think one thing that, we've talked about in the past is, sharing this work at conferences, and I think we've submitted a few abstracts. We've been able to talk about it on a larger scale and get more people kind of in tune with what this program is, how it works, and then sharing our lived experiences through it and our embodied knowledge through it for people to see the impact of that. And I want to say impact meaning, I've been promoted twice since I finished my PhD. I've had the strength of so many others, of between my ancestors and other community members who look like me and share the values of the same as me, to propel me and support me through that. I also wonder in how, when we become alumni, how we can then, me working in New York State Department of Health, be able to create my own learning collaborative, or take some of these tools and start sharing and spreading them in ways that, MLP can't serve everybody. And even, with the endless resources we have, there's so much work that needs to happen on multiple levels, as you talked about, that really take systems to be transformed. And so I think, as champions of MLP, as champions of NASTAD, and the amazing work that you all do, I really would, call to action to my other MLP alum to really go back and talk to their health departments or the spaces they work in, and create those spaces of working groups, or lead the racial justice initiatives within their health departments, the health equity work that needs to happen. And so I think that's how we kind of sustain it, but continue to spread the knowledge and wisdom that we've gained from that space. So those are a couple of tips that I have, but
That's awesome. Thank you. Thank you so much. I think it's really, I really appreciate the very detailed thinking that went into that, and the opportunities that creates. Ultimately, if we're investing significant effort and resources, and we want to see those resources materialize in actual leadership advancement and leadership opportunities, and transforming the leadership within health departments to reflect the communities that are most impacted.
Absolutely. So I see that we're at time. So Stephen, thank you so much for a great dialogue. I really loved getting to know you more through this. And really, I wish all of you participating in the next few days to remember that our presence makes a difference, and an impact on the world. We all have unique gifts the world needs, and that public health needs. So remember your worth, and let's value our infinite worth together. And when you know your worth, your impact is infinite. And so I'm really confident that our collective effort will, start responding to ending epidemics and syndemics. And I just thank all of you for your time and attention. So I'm going to pass it over to Rachel to keep things moving along. Thank you, Stephen.
Thank you. Enjoyed it very much.
Great. Thank you so much, Jennifer and Stephen, for a fantastic conversation. I also have to say, clearly, two Lees are better than one. So thank you all so much for holding space with us this morning. Excellent. So let me just queue up my slides. So hello, everyone. My name is Rachel Browning. I am a manager on the health equity team at NASTAD. Today, I'm grateful to be holding space with you all to discuss the intersections of telehealth and health equity. In today's panel, we will hear from two speakers who will provide their perspective on how we can use telehealth approaches to not only provide healthcare, but promote health equity. For many of you in the audience today, telehealth has been the main means that you have been able to connect with clients over the last 2 years. And although we have seen a lot of progress at the federal and state levels to decrease barriers for health departments and other organizations to implement telehealth programs, the future of telehealth expansion is still unknown. Current gaps in technology access, technology literacy, and service and payment parity across insurers still impose barriers to expanding telehealth services. Before we begin our conversation today, I wanted to hear from you all on your perspective on the longevity of telehealth within your health department. Do you believe that telehealth services within your health department are going to increase, or will they decrease as we acclimate to COVID-19? And we'll launch a poll through Zoom so you can participate. It should pop up on your screen now. If you're unable to access the poll, feel free to also include your answer in the chat function. Have a lot of answers coming in. Once it seems that we have a quorum, I will end the poll. So another like 5 or so seconds for folks who are waiting to answer. Excellent. I'm going to close the poll. Right now, it looks that we have at about 94% of folks saying that telehealth is a long-term solution that we should continue to invest in. I agree wholeheartedly in that as well. And about 6% of folks say that it's a short-term solution that we're using right now to respond to COVID-19. For folks who are interested in expansion of telehealth, we have two speakers today who will be touching on that in their presentations later this morning. If we've learned anything from telehealth, it's that it can and should be used to do more than provide healthcare. Telehealth has the potential to increase access to technology, particularly through programs which provide digital devices such as phones and tablets. This has allowed clients to connect with others, as some have been isolated due to stay-at-home guidance, as well as to easily access supportive resources through groups like mutual aid. It is also an avenue for clients to connect with supportive systems, which may include folks like caseworkers and case managers, mental health counselors, and other peer support groups. And lastly, the pandemic, in some cases, has forced the offering of telehealth to all clients, thus including communities that are not traditionally the first to be offered innovative healthcare delivery strategies. And before I move on to kind of highlight some of the overarching points that our speakers will be touching on today, a lot of our conversations this morning will also be centering clients and how they engage with telehealth. So I wanted to get your opinion and perspective on what you believe is the primary reason why clients within your organization or health department are not engaging in telehealth. And a Zoom poll should appear on your screen momentarily, and you can answer via the poll, or if it's not working, feel free to answer in the chat. And if you also answer H, which is none of the above, I encourage you to write your primary reason within the chat. Cool. So it seems here that we have a little bit of a tie. about 36% of folks are saying that the primary reason is a lack of access to broadband internet or cellular data. We know how important this is, not only to have digital devices, but be able to use them by having access to the internet, and then also access to data if you're not in a place with Wi-Fi. We also have generally lack of access to technology. I think we know this to be very true. It makes a huge difference when folks have readily accessible technology versus if they need to travel potentially many miles away from their home or even from where they work in order to utilize computers or other types of technology. And then some other people have answered lack of awareness and understanding of telehealth offerings, and then also lack of digital literacy. And our speakers today will be touching on a number of these topics. So if you have any specific questions around readiness, I encourage you all to ask them during the Q&A portion. So once again, thanks to those who filled out the poll. In this panel, our speakers will be discussing the barriers to readiness amongst clients and staff, strategies to expand telehealth programs while also centering health equity, and providing lessons learned from implementing telehealth programs. Our first speaker today, Paul Liberty, is an administrator for medical services with the Rhode Island Medicaid Division at the Rhode Island Executive Office of Health and Human Services. Paul wears many hats within his current position, including the project director of the Ryan White Part B grant, the director of the HIV Provision of Care and Special Populations Unit, as well as the director and founder of the project Rhode Island HIV Coexist. Our second speaker that we'll be hearing from today is Michael Murphy. Michael is the executive officer for the Medical Advocacy and Outreach, Officer for Medical Advocacy and Outreach, also called MAO, based in Montgomery, Alabama. MAO provides health and wellness services to people with HIV, hepatitis C, and other health conditions living in Central and Southern Alabama. Prior to working at MAO, Michael served as the interim executive director for the Southern AIDS Coalition. His experience living and working in rural areas of Alabama has helped to instill an extra sensitivity to the specific needs and cultural differences that rural communities experience. Paul and Michael, it's wonderful to have you here today on the panel. Following both presentations, there will be time for questions for our panelists. So please feel free to utilize the Q&A function in Zoom to ask your questions. And Paul, I will turn it over to you for the first presentation.
Wow, thank you so much, Rachel. I appreciate that kind and generous introduction. And it is my pleasure to be here with all of you today, particularly Michael, as we go through some very interesting, intriguing, and challenging aspects of what happened to us as a world, and particularly as we bring it into the HIV sector. It gave me, as a social and behavioral scientist, a lot to chew on, and I'm happy to chew on things relating to social and behavioral aspects of our health. I sort of renamed my segment a little bit so that I could address the health equity, also be honest with you, as Rachel mentioned, I'm in a very unusual situation where I'm part of the Executive Office of Health and Human Services, but also I have a Medicaid role as an administrator for medical services. So the Ryan White program is located in this environment. And we were previously located at the Rhode Island Department of Health, where I served as the director or in chief of communicable diseases. So over the last 11 years, we've evolved, and equity's been at the top of our list always. And as we sort of, like you, went through this pandemic, we started to think of ways by which we could be better in touch with our clients who are the most vulnerable of all. Next, please. So today, I'll just discuss some of the challenges related to what I perceive as inequitable access to telehealth and digital health technology. I'll address the challenge with TAVI Red and telehealth, and talk to you about something that's evolving now, so I could share with you some of the rudimentary and bottom line issues that I believe are important so that we can solve some of the issues that we notice around inequity. And then using our digital technology called Tabby Red to promote what we're referring to now as telecase management to reduce stigma and meet the needs of our most vulnerable people. Next, please. It's been really exciting to work on this project. And in order to begin a conversation about telehealth, I think it's important to take a look at some of the data. Next, please. So I did a little research, and thanks to an organization called Rock Health, I was able to really understand some of the inadequacies associated with the presentation of telehealth when we weren't really ready in some ways to present it to all populations. For those that used it, access, availability was increasing. There was a decrease of exposure to disease, for example, like COVID and the flu, because oddly enough, when we go to our medical facilities, we can be exposed if we're not properly protected. And yet, in the same situation, a majority of cases also were not seeing the kind of access and availability that we would have liked. So inequities rose, and inequities had to be noticed. And those without broadband internet compatibility or access to smartphones or other devices couldn't participate the way we thought. So they were sort of brought to the old-fashioned, let's call somebody up routine, which wasn't the ideal situation during this time. So everybody that I think we were exposed to, there was some significant disadvantages from health equities that we needed to see and come to grips with. It's not equity to simply provide every individual with the same resources. That would be equality. In order to achieve health equity, resources must be allocated based on an individual needs-based principle. Next, please. These are some of the things from Rock Health that I talked about, and this was really around United States polling of adults who own the following devices. And if you can take a look, 97% own cell phones and 85% own smartphones. So right there, that baseline told us that we've got a little work to do. And depending on where you are in the country, you may be surprised that people just don't have access to smartphones. A matter of fact, we were, and in the initial cohort we did for our digital health program, 100% of the individuals we polled, and this number was less than 100 people, did not have access to smartphones or the internet. Next, please. And the reason why I'm bringing this up is because it's really important to take a look at these things. You've heard them before, but to really try to bring them back to your population and understand access to broadband, access to things like smartphones, access to tablets. And this data shows us that, particularly as it relates to some of the more progressive digital technology, our populations who are really vulnerable just do not have them. Next, please. So at the end of the day, when we're looking at this kind of data, I also really felt that we needed to try to judge the capability and the capacity of our patients and our clients to really access some of the other things we hear trending. It's not just about telehealth. And today, I'd really like us all to kind of contemplate the differences between telehealth, telemedicine, and what I'll be introducing in our program is telecase management. I think the definitions are different. I think we need to appropriately put those definitions in the right place at the right time for the right people. And, I'm not going to go into those today, but if you'd like, we can have a discussion at another time to talk about those definitions and how relevant they are to equity. But these are just some concepts that I thought were important. And equally, and from an equity perspective, rather, we have to really consider whether our populations have access to this information. It's really critical. Connectivity is critical. Next, please. So basically, what I'll talk to you a little bit about is our digital technology called Tabby Red. We recently have been very excited about the evaluation that we have undergone as a result of NASTAD's selection of our program to be a part of a SPINS grant. And we had an independent evaluator that assisted us throughout this process, and our evaluation results are in. And so I'll be sharing a little bit of that with you. The most important thing to know is that Tabby Red was integrated into the Ryan White program. And we tried to think of ways by which of all of these categorical services that Ryan White offered, could benefit from a digital technology. Next, please. The concept here is really understanding what the unmet needs of the population are. So we did this process at the onset of COVID as well. We do it regularly, but when we were trying to determine what's the best way to reach out, as all of you were, to our clients and our patients, we had to really dig deep into the unmet needs related to what it is that our providers in Ryan White, at least, and our providers in Medicaid were saying they needed to continue to have the greatest connections with individuals. Next, please. And so we felt that using a digital solution to promote health equity was really important. And my motto has always been that I'd like to, dream big about making sure that vulnerable populations come first. And when we had the opportunity to put a smartphone in their hands with a pretty advanced digital health program, I took it. And I took it on the basis of not only that was a good thing, but also the research that came along with the product that was developed by 360 MedLink and TAVI. Next, please. We all, this is just a quick way of looking at TAVI. It's a time saver for patients and providers. It's got built-in assessments and analytics. You don't have to sit there for hours, really looking at data. There's an there's an artificial intelligence involved so that in a good way, it really monitors the behavioral decision-making of individuals. It's vastly different than other health platforms. It's intuitive, innovative, and intelligent, and its exceptional data runs have really helped us out with such things as HRSA reporting and other things that we really feel are important to give back to the community providers as well as our people living with HIV. Next, please. So at the end of the day, when we're taking a look at addressing the challenges, these are the modules. I won't go into these in detail, but all of these modules have made a huge difference in our patients' lives in terms of really getting them involved with an inordinate amount of behavior change. It happens really quickly. And as a social and behavioral scientist, I'm amazed at how quickly it happens. We believe that the reason for this is through serious gaming, that we attached a very serious gaming modality to it. As I mentioned before, artificial intelligence or AI is associated with it. I don't know about you, but if I look for shoes on Amazon, I'm inundated with shoe, marketing. It seems like till the end of time. They seem to know my size. They seem to know what I like, what colors I like, and that's a little frightening at times. But when you turn AI into a very positive thing to enhance behavior and positive health outcomes, as TAVI Red does, we found that these interactive quests that they go on, meaning the clients and the patients, they could be assigned these or not, is really dynamic. Next, please. So conceptually, these are the things we were focusing on. We noticed that there was a moderate amount of individuals in our program. And when I say our program, Ryan White and Medicaid, that had some problems with medication and medical frequency associated with the HIV continuum of care. So antiretroviral therapy was a struggle for some people, and that was so noted during the self-assessment phase when we were doing baseline. All of these things were really important. I won't go into all of them, but I think one of the most important things was interoperability with other data sources. We connected it to CareWare, and we are now going to connect it to some of the Medicaid data that we have. We also tried to really develop an army, so to speak, of case managers so they were able to monitor patients through a console. Next, please. So these are the basic functions related to what we're looking at. And I'll be honest with you, in the beginning, I wasn't a tech guru by any stretch of the imagination, and I am still not. So when the developers asked me, what do you want to get out of it? I said, I really want to engage the clients so that we go beyond calculating success based upon a hit. I didn't think a hit was really successful in my mind. That told me that people were really getting involved with something. I wanted to see engagement, and that engagement is really measured in a performance measure sort of kind of way when we're looking at what quests they went on and whether or not they successfully met the quest. We wanted it to assist all of the elements that showed up on that needs assessment. If I if you remember what I said, that needs assessment was really critical. And then, of course, we wanted them to have fun with this. These are the aspects, next slide, please, of what we're doing. And then, of course, the gamification features is something that I think took everybody over the edge as it relates to behavior change. This is not equivalent to gambling, of course. We, really had an ethicist on our team, a psychologist who was studying gambling addiction. So we wanted to make sure that this was not something that was going to take people literally over the edge if they had been in recovery from gambling. Next, please. The concept of what we're looking at here in terms of sampling populations, all I'll say with this slide is that we met and oversampled for race and equity. Next, please. And these are just some other factors that I'll skip over. Thank you. Next, please. Just in the interest of time. The notion, I noticed that earlier someone said that a lot of people in their patient population were unstably housed. So TAVI-RED was able to and still is able to keep track of people who are unstably housed through a self-assessment. In the beginning, when we sampled that population, that was less than 100, about 34% were unstably housed. About 20% of those really were in a situation where they were couch surfing, and the remainder of those were either homeless or not able to find a home. Next, please. So we're able to look at inequity through the data runs that we have. Depression, housing status, social determinants of health, all built into this. Next, please. And we took this information to really foster an understanding of why aren't we meeting the right people when we want to open it up to telehealth? We did give them a smartphone, and that helped a little bit, but the reality is there were still some things associated with telehealth that we weren't getting at. Next, please. The anxiety level of individuals that last slide showed, was hovering at about 30% or so. We decided that we needed to rethink telehealth, telemedicine, and telecase management became part of our thinking so that it would fit into the whole ecosystem of working in sync with other health inequities that we were working on. And this is just a broad-based presentation of what those other ecosystems were. Next, please. And of course, this is the coordination, the management, and the planning sector of TAVI, but it does involve a console and a dashboard. It's really comprehensive, as I mentioned before, interoperable with other data sets. Next, please. It has a virtual coaching aspect, which we found was really important for those people that didn't want to ask their doctor a lot of questions. And so these are some of the basic elements that I believe are the undergird of TAVI, data evaluation and reporting capabilities. We were able to really give our independent evaluator data at a moment's notice as a result of everything that this platform stored for us. So it had immediate ADAP and premium assistance enrollment through a customized portal that was designed by AJ Boggs called Lafia. Lafia is talking to this platform. Careware is talking to this platform. And our hope is to continue to create more interoperable mechanisms with the platform. Next, please. This is the rudimentary aspects of what we deem are important. It sends announcements, it schedules appointments, it reviews progress to encourage and support. That third bullet is important. A lot of research was done during COVID where a simple text message in a positive form could really help patients and clients who were struggling through many of the things, particularly information that may not have been accurate. And they were getting anxious and nervous, and they were calling our staff saying, could you help us here? And so what we did is we were sending out positive messages, hang in there. If you want to really get a COVID test, if you want a booster, here's where you need to go. Next, please. And I think at the end of the day, this concept of telecase management is evolving with us. We believe that we should begin to think about new standards of care. We should begin to think about creating standards of a new profession, not only just telehealth and telemedicine, but telecase management. And when I say standards, please don't beat me up. I don't mean to create more burden for providers, but I do believe there's a necessity if reimbursement is part of the criteria here, not only Ryan White reimbursement, but Medicaid reimbursement, that the provider should be following a set of principles, at least at the lowest level, to create a minimum response to the needs of the patient. Next, please. And so the concept of telehealth being transformed into telecase management for us just really meant that we had to create a few extra modules. So we created a COVID-19 modules in response to some of those needs that people were surfacing with. We tested this with our consumer advisory board. They were the beta testers. We continue to test it with them whenever a new module is developed. That's a really key component to equity, I believe. And so the concept of TAVI-Red nuancing itself with this concept of telecase management, it's being seamlessly integrated into our console of TAVI Pro. And in 2022, we'll be rolling all of this out, at least a new, more assertive methodology of telecase management so that our case managers can integrate it into the care plan. And one other thing that we're integrating is this concept of the 8 dimensions of wellness, which I can talk about at another time, but I really believe during these times, we need to find some light during the dark times. I think I'm out of time, so thank you so much.
Thank you so much, Paul, for that fantastic presentation. For those that added questions into the chat or the Q&A function, we are keeping note of those, so we will make sure to ask Paul those questions after our next presentation. So next we'll be hearing from Michael Murphy from MAO. So Michael, I will turn it over to you.
Thank you very much, Rachel. I'm going to share here real quickly. Hopefully it will go well. Right. If you all will tell me if you run into questions, please, or can't see my screen, please let me know. So I really want to tell you all how much I appreciate this opportunity to share with you a little bit about what we're doing in Alabama. Real quick, I'm going to give you a background, but I also want to talk about specific things that I think for anyone serving rural and small town, not just America, but anywhere, things we kind of need to be aware of, why there's so many barriers in the rural and small towns, but also what we can do with telemed or telehealth to maybe address some of those issues. So that's what we'll be focusing on. We do quite a bit of work as a 501c3, actually, really doing a holistic approach to care. And we do a very large swath of areas you'll find out in just a second in the southern part of Alabama. So our service delivery process, let me address who we're funded by. So we are a Ron White Care Act program. We're a Part C grantee, and then we're a Part B provider, and that's through the Alabama Department of Public Health. And we have really had a great relationship with ADPH, and you'll learn about that more in a second. In addition, we are very closely linked with the UAB Family Clinic to do Part D work with families and children here in southern part of Alabama. And we're really unique in another way that we are the AIDS Education Training Center actually for Alabama. And as a nonprofit, that's kind of unusual. Most of these programs are in academia. And so we were really appreciative of Vanderbilt University and the CTEC program allowing us to be a partner in that. As you can tell, we do a little bit of everything because we have to. We are doing medical care. As was mentioned earlier, we're doing Hep C work, plus we do a lot of work such as NPEP and PrEP. And then our social work services, just really, those are our roots. That's where we came from as a community-based organization back in 1987. And then you'll see we're doing a lot of education, both community-based and professional training. And then we're also doing a rapidly growing work in mental health and behavioral health services. And that's become even more impactful in these recent years. For our area, we cover 18,675 square miles. We are in a region of the state, the very southern part. And I want you to take note of two pieces here. One, we have 4 hub sites, and those hub sites are really our buildings And we sort of move from there. Each of these have clinic spaces. And in Selma, Alabama, which many of you do know Selma, it is a clinic only because we have a great relationship with another community-based organization there called Selma Air, and they do the social work and support services. But what's unique with us is because we cover this 18,000 plus square miles, we utilize satellite clinic systems, and these are actually part of what we term the Alabama eHealth program. And integral in that is the fact that those satellite clinics are based at Alabama Department of Public Health clinic sites, our FQHC, Federally Qualified Health Center partner sites, and even we've been working a lot with UAB for many years in Selma. And those programs allow a collaborative work where we're doing this direct practice telemedicine into these particular sites. And so this is what's a little bit unique for us. We've been doing telemed for 9 years now. And these hub sites, satellite clinic sites, have been really useful. And what we've used is a very high level encrypted system of telemedicine technology. And then we have team members who are involved along with our partnering site membership. So who do we serve? As you can tell, the great majority of the people that we're serving are from African American and Black communities in this area, with the second largest notable group being white or Caucasian. And then our gender identity piece is kind of going through a little morph. We've always had a large number of cisgender women, and that continues, and that's probably going to continue for years to come. But we're also starting to see a new rise among trans community, people of trans experience. And that's been, I think, in a good way, showing that in the past, women and men of trans experience were leaving our region because of, truthfully, lack of services overall, but also safety issues. And so now the world has begun to change, even in small rural Alabama, where more and more people of trans experience are staying. And I think that's going to be good for the state. It's going to be certainly good for these communities that the individuals are living in. So we are seeing a growth in the community, in the trans community. And then, as you can tell with our risk factor, the majority of people that we serve identify as heterosexual transmission. And that one has certainly been influenced by the cisgender women experience that we're seeing. So influences on care. I think you have to start off with our area as just the massive issue, and that is poverty. You look at Alabama in general, we're just a poor state. We are the 6th poorest state in the union. And out of our 67 counties, 64 have poverty rates higher than what was then the 2018 national average, and it has not gotten any better. So you're looking at, in our region, if you remember that picture, we serve that southern area where the darkest counties there indicate the highest rates of poverty. These are states, and this is a state where about half the population of our state live in small town and rural communities. And if you're in Mississippi, you know it's even greater than that. I think this is an issue that we've got to look at overall for all in public health, whether you are governmental aid or if you are community-based organizations. The equity issue is still great if you look at what urban, metro, and suburban communities have access to versus rural and small towns. If you look at data after data, and I encourage you to seek it, the reality is if you live in rural and small towns in this country, your likelihood of dying from a lot of issues is far greater than if you lived in these other areas. And it's predominantly because of access to care, but there's also another issue that we'll discuss, and that is health literacy that we must address in this country. So this is where our influences on the care have been, is poverty is just great in our region particularly. And then we also have the limited transportation. Alabama is one of 5 states that decided not to do public transportation funding. So anything we have is we're depending on federal dollars, and only 5 of our 67 counties have even something remotely close to a full scheduled public transportation system. And in many, they have a rural, but they're not as effective because they're not on a full-time basis. And then this one I want to share with you, and those of you who have seen my program before, you know this is an issue that I keep referring back to. When you look at healthcare disparities in America, and especially in the South, I think you have to look at history, you know, and the fact if you, again, remember this previous slide that I just showed you, where you had the poverty in these rural areas of the South. Well, look at this one, and you'll kind of get a little bit of a vibe on why that is. So here what we have, those areas, these balls that have the larger blue zones in them, those are areas, the ones with the larger blue, where individuals who are identified as slaves were located back in the 1860 census. Now, if you look at that point, we know poverty still exists certainly in the northern part because of the mountain communities, and the Appalachian poverty is still very real. But in the southern part of our state, this influence is still significant because what happened, there was a massive health disparity and wealth disparity that grew out from that plantation culture, because you had a few people with lots of money and the great majority with nothing or very little. And even after 1864 and 1865, you can tell how that, with the poverty signs we showed earlier, that's not changed. So this history is important, and it is a reason why, even as I try to talk to my state legislators and my congressional reps to indicate the decisions we're making right now just on healthcare and how to assist communities that are not being served, what's doing now is going to impact 100 years from now. And we've got to learn from our past if we ever want to be able to overcome it. And especially for a state like Alabama or other southern states, there has to be. So then you add on to all that, this professional shortage areas. Our provider landscape is sad. We have 67 counties, and 63 of Alabama's 67 counties are partially or entirely health professional shortage areas. And again, look at the southern part of the state, look how disproportionately heavy that are, especially in the West. Then you add to it, if you're looking at mental health coverage, it's even worse. Because on this one, we are 66 of our 67 counties are partially or entirely mental health professional shortage areas. Now, I'm not talking about psychiatrists there, I'm just talking about therapists. And I'm not talking about HIV or STI care on the professional shortage area on the medical, I'm talking about any kind of care. MD, DO, NPs, PAs, we are in just a desperate process in our state and in many other states, especially in the South. So I want to talk a little bit, and I appreciate Paul mentioning earlier about the terminology of telemedicine and telehealth, and then the telecase management piece that they were discussing, which I think is awesome. So our telemedicine for us means a video chat environment that's between a physician or a nurse practitioner in our case and a patient with a nurse on the other end. And right now we use nurses. I think in the future we could certainly look at medical assistant. We could certainly look at community workers, community health workers. I think that's a good option. But we utilize this method, and in that we have a high definition camera and a video screen. And so we do peripherals like a Bluetooth stethoscope, Bluetooth otoscope that are mated between the two sites. So this is telemedicine for us. This is a direct practice, as if our recipient were being seen in the exam room with our medical provider. In this case, they're at a site at one of the satellite clinics, which are at the health departments and at the federally qualified health centers we partner with. And then we're doing that specialty care. We still can see them in person, and we do, but they also can provide this as an option. And for a lot of people, they wonder about this encryption, you know, how secure, and we actually use the encryption in line with what the U.S. Department of Defense is using. So I want to take real quick note of this. So people wonder, can we afford doing something like this? And the answer is, yeah, you can, but it's expensive and you have to prepare for it. So if you're talking about telemedicine, if you're looking at like one unit where the provider's on one end, she or he would need probably a unit with the peripherals that would be about $2,100 in cost for that particular setup. And then you'd have everything kind of linked in under the broadband system. Under the telehealth cart, that would be similar to what you're seeing with this particular consumer and recipient with a nurse. That system could cost about $12,000, and it's actually going down as the technology gets better. And what you could do then, you'll have your equipment set up, linked in, you're using everything on the Bluetooth and the others, but then it's also being, you're going to have a monthly cost to be able to keep it rotating along. So I just wanted to share that, and we can certainly give you a lot more information, and you can get in touch with me after this program. And when we started off, the whole idea was that ourselves and our two partners in this project, which were Thrive Alabama up in Huntsville and Watley Health Services over in Tuscaloosa, Alabama, that we would try to initiate a system of covering some of Alabama's 67 counties. So that's how we started off in the plan in 2008, and then when we really launched it in overdrive in 2012. And so what we have now kind of looks along this line, that we do actually have a fairly good network. Some of our partnering programs use it differently, and it's great, but we are seeing that kind of linked in our particular system. And then we actually moved ahead to have a telemed bridge that we put in to provide more encrypted services for people outside of Alabama if we had a partnering organization that wanted to be able to utilize it. And so here's what we've got. Our telemedicine program, and then our telehealth program, which would be those services not delivered by use of the Bluetooth peripherals. We're currently doing direct practice clinical care. We're doing preventative treatment, do PrEP monitoring, the pre-exposure prophylaxis monitoring. We're able to do telebehavioral health counseling and service delivery. We're doing social services monitoring and client support. We're doing virtual training, including community-based and professional in the community. And then we use all of these, we utilize them for planning within our agency as well. And so we're able to use all of these pieces to be able to operate at least a pretty solid option for service. And so I want to show this just from a data perspective, and what happened in this case during when COVID hit. So if you looked at back in 2019, before it really came upon us here, we had about 279 folks using telehealth, which would be predominantly the telemed link. We were doing direct practice. And as you can tell, the majority of those were pretty good viral suppression on their HIV status. But then in clinic, it was probably a little bit less, but a lot of the folks out in our telehealth actually in their telemed were very consistent, like in rural community, if they missed in the past, when we come out, and we still do, we do a touring group with folks on the van to go visit those sites. In the past, if you missed it, you might be another month before we could get back down there, or they would have to travel long distance. Well, now we eliminated that because we could go back to that site. And so our retention rate among our telehealth folks in 2019 was good at 85 actually. But our viral load suppression was really good, and I'm proud of that. You jump into 2020, and that's when everything hit, and we began to use at-home telehealth, which would include for us phone service, as well as people using smartphone and computers to link in. And when we did that, you saw a really kind of a unique jump. We had a big use of our at-home phone. We also still had good telemed, meaning out in the satellite clinic sites. And then our at-home telemed and telehealth began to be pushed forward. And that was useful. In fact, if you look at the bottom, patients who are at home who are using, again, telemed in this case really means telehealth, they were about no-show rate of about 8%. And a lot of that one was because we had people who were constantly getting in touch with them and working them in to make sure they could access the link. And we had, no shows on about 6%. We really actually did about 6 people. So we actually did really well. And a lot of that was engaging them. But then the at-home by phone really came into play. That one we still had no shows. That was a little higher percentage, but we had really good participation. And all of those, when you look at the phone piece and the at-home telehealth, it really was only viable because the third-party payers allowed it. And that's something that was mentioned earlier, I think, by Rachel. Without that, a program like ours as a nonprofit, we couldn't do it. We have to be able to at least get close to parity on getting reimbursed for the service. But there's so much benefit to that. And I think that's something that we've all got to look at more so to keep third-party payers, including CMS, to make sure that they realize how important telehealth services are. So this was just a note for all of you administrative folk. We served in a 5-year study. We were able to reduce travel for our patients by 662,000 plus miles. We saved, because we reimbursed a lot of folks to get to their clinic sites, over $361,000 during that 5-year period. And then the average patient served, they were able to save about 781 miles on average per year. So that's been good, useful for us and for our recipients. So lessons learned. I think, telemed and telehealth for us allows our rural people affordable access to providers, no matter where they are. And it also eliminates a lot of that financial burden that comes from traveling. Because you got to remember, this is in urban and metro centers too, but in rural, if they don't have a vehicle, they have to pay somebody, and it's going to be high. And so this was a chance of getting much closer to their home environment. It allows for low cost maintenance on the chronic conditions. And I think that especially for the telehealth work and the phone work, smartphones and regular phone work is really useful. And it even helps providers to get access to our specialists, even at the health departments and the FQHCs, that they could contact us in the process. And I really do believe it delivers cost-effective specialty care, particularly to rural environments. It really is going to be something for the future if we can get enough research on it, which is something that we sorely need in rural care and in small town care in our country, is more research support. So here's a statement I'll make for you as I'm finishing up. Part of the thing, and I appreciate Paul, because I think he was right on it too. The lesson learned for us is the more options available to recipients and patients, the better chance they will find a delivery system that fits their life. And I really want that to sink with you. Instead of us as providers, us as think tank people or whomever, we can say all day what we think folks that we're seeing in community health need. We need to listen to them. They will tell us. And I want to tell you, we'll have to listen to folks in rural communities, because they're going to come into all this already with a health literacy issue. Rural people, country people, folks even in some urban areas, depending on their cultural background, they really do not trust medicine. They do not trust organized medicine. They just never had. And that doesn't matter what their ethnic or racial background is. It cuts across this, it cuts across the world. Rural people are not accustomed to having access to good care, nor are they comfortable with it, because they don't know what it means. They go homeopathic and they always go back. So we're going to have to help educate our people in rural and small towns on why preventative care is important, because they don't. They're crisis oriented. They only go if it's a death thing. And that even many times our elders are going to not want to do it, because I know I'm from rural America and trying to get my grandparents to go was an impossibility. So I really want to say that one right up front, that has to be. So we're going to continue to do face-to-face. We're going to do direct practice telemed clinics to get them close to the people to where we can use all the peripherals. We're doing telehealth options, and I really pray that will continue. Phones, cells, et cetera, will continue. And also, I think the use of our suitcase unit, which is next on our line, which that unit you're seeing there probably will run about $8,000. But our comment there would be that we would be able to take the care into the community with, again, a nurse or even a community health worker in the future. And that's all linked through our encrypted system back to a province. So we can take care back to the home, which for a lot of people could be useful. And particularly in rural people, they'll be a lot more amenable to that than to have to come into town or come into a city that could be miles and miles away. And then we are using mobile medical clinics as well. So I will close out with this statement that, in my opinion, let's listen to the people that we serve. And also, I'm going to ask you all to think differently on something. Let's not assume the people we are serving do not have access to things, nor that they could use telehealth or that they have any of the above. Let's ask them. Get them to tell us, do you have access to this phone? And like what great program Paul's doing, then we can help them get it. We have iPads that we provide our pregnant women because we have had a lot of pregnant women living with HIV who are pregnant. So we utilize that. But there's things we must talk to them about and let them tell us. And let's not assume it when the big think tanks in the sky that none of the people we serve can do this because they're too poor or they're not, don't have the education levels. No, let's listen to them. They'll tell us. So I thank you all. And I'm going to, hopefully, if I do this correctly, turn this back over.
Great. Thank you so much, Michael, for that presentation and also for ending on really thinking about client-centered approaches and also that clients know best about what they need and we should just ask them. So thank you so much for ending on that note. I want to start with some of the questions that we've been receiving throughout this panel. And Michael, I'll start with you with our first question, which is, what is your insight into addressing clinics that successfully use telehealth during COVID, but are now phasing that out solely because the in-person medical visits are reimbursed at a higher rate? The person who asked this question also mentioned that this is super frustrating for their clients that truly enjoyed using telehealth for appointments, as it kept them from missing things like work and school while traveling to the clinic and or waiting in the clinic for their visit. So Michael, I will turn it over to you.
Sure, thank you, Rich, and thank you for the question. I really believe you look at it in two ways. That the reimbursement thing is just such a reality. I mean, that, and especially for clinics and with the high cost of medical care, I think for us, we've got to press through all means that third-party payers don't reduce this parity rate. And in some cases they are, and we've got to stop it. And that includes, we've just got to get out there, and this could be a project for NASTAD to even take this on, that we must stop that, because what was stated was absolutely right. There are recipients and consumers of services that for them, it engaged them. And they had more control over their care in this case. And I think that's worth every moment. And I think even some of the larger ones, like in our state, Blue Cross Blue Shield of Alabama believes in telehealth. So that's good. We've just got to get them pulled more into it. I think one side note too, we've got to make sure that medical providers don't lose. Some of them are so oriented, like, no, I want the patient right here where I see them every time. And I appreciate that, but I think they can still work a system to be able to get recipients back into care, but they can't reject telehealth and telemed either. And the medical providers have to accept that as a future too. And God bless doctors and all the above, but sometimes they're a stubborn lot, and we have to try to convince them to listen to the people we're serving. So just a statement.
Thank you, Michael. So I'll transition to you, Paul. We had a couple of questions that came through specifically about TAVI. So I'll start with the first one, which is, does information on a client receiving one Ryan White service auto-populate into other Ryan White services through TAVI?
So we've integrated it into Careware, and our focus is on performance measures. So you have to remember that these are different sort of access points, but they're also very different in terms of the deliberation of how a client answers a question. On the TAVI side, it's self-assessment, and the evaluation that we did, we have the capability in state to back it up to their clinical records, whether those records be found in ADAP or in Medicaid. So that's an important thing, because a lot of the naysayers to something that relates to self-assessment is this accurate information? So if somebody self-assess their viral load suppression and their memory may not be accurate in terms of what it is, I know if you were to ask me what my cholesterol was last measure, I may give you an answer that may not be 100% accurate based upon my recall bias. But point is that we back those things, those critical measures up. So there is some integration going on. AJ Boggs has helped us with this. They're a consulting firm that works with a few states out there. They have a wonderful product called LaFIA that we integrated into our ADAP program. So again, this is a nuance of interoperability, if I may. It requires a little bit of diligence and attention to how those things get integrated.
Great, thank you, Paul. And one more question related to TAVI that came in that I want to address now. is there was a question as to whether TAVI can also be used for PrEP management.
Yeah, we're looking into that. Of course, under my tutelage is the Care and Treatment Program, and the concept of prevention under PrEP. We've been looking at the nuances associated with this digital technology. So right now, there's a pharmaceutical company interested in how they can incorporate this digital health product into their PrEP programs. They specifically want to begin with adolescents. And there's a lot of very interesting components associated with that, particularly as it relates to serious gaming, which I'm hoping may be taking us off into the next century. So yes, and right now it's just the developer of the product, 360 MedLink and TAVI, is in negotiations with a farm company, a rather large one, to see whether or not this could successfully be integrated.
Great. Thank you, Paul. And just a reminder to folks in the audience that if you have further questions, you can utilize the Q&A function at the bottom of your screen, or if you'd like to input them into the chat. We're actually going to go to an audience member, Levi Berkshire, who had a question. They raised their hand. So Levi, I'm going to unmute you, and you can either pose your question to Michael or Paul, or to both folks, if you prefer.
I apologize. I didn't even notice that my hand was raised. I don't even know how I did it. So I apologize for taking up time.
Oh, no worries. No worries. Always happy to hear from people in the audience either way. Well then, Paul, I'll go to another question for you around TAVI, which is, will HRSA be providing contractors with TAVI, or is it something that must be purchased?
Yeah, right now, while HRSA funded this through the supplemental grant process, and we've been funded successfully for 4 years with this project, while they funded it, there's no specific commitment that has been made outside of what we've done in Rhode Island. So in some ways, this has been a concern of ours, because we definitely wanted to prove the aspects of its viability in states, so that the transferability, generalizability was there. So we made a promise to HRSA to work on those bugs. And now that we had the independent evaluation that I mentioned earlier with NASTAD's assistance, we now have been designated as a best practice. So we definitely have been able to communicate this to HRSA, but no commitments have been made. Right now, at present, services would need to be independently contracted with the developer, 360 MedLink and TAVI. However, I've been used as a direct conduit for states, because there's so many nuances associated with bringing this to a state to maintain the validity that we sort of found. But more importantly, there's an infrastructure development that has to occur. So because we experimented in the smallest state in the country, and we were able to get our hands on things a lot quicker in some cases, we're not Texas, we're not New York, we're not California. That's my disclosure. We could probably fit inside Texas with room to grow inordinately, but we have pretty big fish in the ocean. So I'm just saying, the reality is that you really have to kind of put a stethoscope up to your infrastructure, and we can help you do that. We also have an on-the-ground manual that we've developed. So there's a lot of, sort of elements associated with what you have to do to prepare for this.
Great, thank you. And Michael, I had a question for you, because you kind of closed with talking about getting medical providers on board. I'm curious to know how you and others at MAO kind of secured buy-in from providers in order to implement telemedicine.
Sure, thank you. You need at least one champion among that group. It's kind of like peers, always make a difference. We talk about peers among our recipients, but peers among this professional core, like medical MDs, especially in NPs in our case, they need someone to say, oh no, we can do this. And we were very thankful to have 2 people early on when they first rolled it out that were, but we as an organization still faced resistance by some of our providers. So we had to do a lot of preliminary training because for some it was the technology. They just didn't want to deal with it. For others, they missed the patient recipient being in the room with them. And we ran into that a little bit with behavioral therapists, but they get over it quicker because they get accustomed to the dialoguing through even the telehealth link, and it was fine. So I think you've got to do some training beginning right off the bat, help to answer the questions and be available to deal with the question. Because if you don't, they're going to really have a problem. They're not going to stick with it. And you just keep feeding it to them and encouraging them, and whatever you have to do to make them feel happy about this process, that's what you do.
Great, thank you. And Paul, the next question is for you. Thinking about costs. So what is, and this is a bit of a specific question, but if you could maybe give like a ballpark figure per se, what is the dollar amount for full-time employees and infrastructure needed like per client or per patient? And could this be scaled up in a jurisdiction with a population that is, 10 times or even 100 times larger?
Yeah, it can be scaled up. I tried to answer that in the Q&A once I figured out how to get back to it. But for the entire audience, costs are really dependent upon the activities associated with the features, the volume, whether or not you need smartphones. And of course, the biggest expense for us is relatable to not only any of the research and development we did, because we customized this. So, but we're willing to share that all with you, so you don't have to incur those costs. So I've notified the manufacturer, the developer, if you will, that anything we did, I'd like it to be passed on to my fellow colleagues, so you don't have to incur those. But of course, the volume of the people that you have would be a cost. The consulting capability of TAVI, which you need for a time being, and then the infrastructure development that you have. I can't stress that enough. So for example, we decided to go with case managers first, and case managers represented both clinical and non-clinical environments. And we started to go with the physicians first, and then the physicians were like, you know what? We think this is a great product, but we're undergoing some studies right now regarding medication adherence, and this might screw us up a little bit. So we prefer that you dance around it by bringing it to the case manager. Inevitably, those two things bumped into each other, and TAVI Red was revealing incredibly high levels of medication adherence, medical adherence, and other things in terms of people who were coming in that were disconnected to care and were not virally suppressed, and within 6 weeks, we had them connected. So we know the value of it from that perspective. So costs are really dependent upon what you need, the features that you have, the data capability that you want. But ordinarily, let me just tell you specifically, the grant that we wrote for the supplemental in Little Old Rhode Island started off around 400, and then we decreased it every year. And I think we're hovering around 225,000 right now to maintain it. We just, so you know, again, we're small. We have about 400 participants in the project, and I hesitate to give you those numbers so that you don't add it up per person per hit, because then it gets a little confusing because we've gotten so much value. Again, just as I offered you the opportunity to have our research and development aspects, TAVI offered the same to us for some of the modalities that they started, and then we built gamification around it. I had a data scientist that helped me with the gamification piece that I wanted, and the TAVI team just developed the software around that. So if you have ideas, they could be brought forward. But again, those research and development ideas have costs associated with it. So I can't give you a direct hit on the cost, but we're happy to talk about it with the developer, and I can arrange that so that you can hear some of the inside scoop on what I'm always concerned about, and that is the infrastructure build and making sure that this settles in a place where it can be sustained without a great deal of cost. That's my concern. And I think it can happen, and it can be transferable.
Great. Thank you so much, Paul. For folks in the audience, it seems we have about 2 more questions that are coming in. So if you have any burning questions on your mind, on your heart, please feel free to add them into the Q&A function or the chat. This question is both for Michael and Paul. And Michael, I'll start with you first. But the question is, any thoughts on using ADAP rebate funding to purchase personal MiFis and service for clients having connectivity issues? And Michael, I'll start with you first, and then Paul, if you want to add anything.
Sure, I appreciate it. I think it's a great idea, actually. I know our state, Alabama's done a really good job on utilizing the rebates to really do a lot because, as mentioned earlier, we're just such a poor state. And so for us with the Alabama Department of Public Health, they've really done a lot of innovation. And I think that's a really good idea, especially with the future of telehealth should be out there, again, as long as those third-party people kind of support it. So I would say absolutely yes to that one. I think it could be a real good use of the money, especially for rural and small towns. I think that's but even in urban centers, there's a lot of people who need that kind of access.
Yeah, I agree. We're transitioning some of the supplemental money into rebate so that we can support some of the ongoing nature. We feel it's a good aspect of the sustainability I talked about. There's also a few major philanthropists that are looking at this, and pharmaceutical companies are interested in it too. So there's a lot of ways by which you could augment the funding. Someone mentioned the Build Back America Fund and the president's need or desire to qualify the need for people who can't access broadband, particularly in the rural communities. But I can also tell you there are people working that are in urban communities, living in urban communities that don't have broadband. So connectivity is important. And for those of you that are interested in that and really finding out the research, Dr. Amy Schoen from Case Western University did a wonderful article on this. So if you just Google Schoen, Sheon, and Case Western University and the issues of connectivity that she studied in Ohio, it's really fascinating stuff, very critical to our discussion today, and incredibly critical to equity. So, these are the undergird of where we, I think, need to begin.
Great. Thank you, Michael, and thank you, Paul. We have one more question that's come in for the both of you all, and I'll start, Paul, with you first. The question is, what percentage would each of you say patients in your program utilized telemedicine with each of, sorry, let me start again. What percentage would each of you say patients in your programs utilized telemedicine with each of your platforms versus ones that prefer to continue in-person appointments?
Yeah, so I want to go back to those definitions, right? And because I think Michael and I are on the same page that when you talk about telemedicine versus telehealth versus what I'm going to bring into the picture now, telecase management, you got to put your arms around those. So I don't have all the data with me, but let me just say that under Medicaid, we've got about 1,100 people living in Medicaid with HIV in the state of Rhode Island. Our denominator is 2,600 people living with HIV in the state. Okay, so that verifies the fact that we're small. Now, with that said, we follow telemedicine activities in Medicaid, and it's been really the majority of individuals that the physicians reach out to participate in this, but the concept of telemedicine, if you're defining it using video interface, no. It's not going to be 100%. It's going to be, they'll pick up the phone, and sometimes, many times, it's a landline. So they've been trying to follow this through. So we don't have good data on the Medicaid population. However, with the Ryan White population, because a sizable amount of the individuals now have smartphones, we're not only giving them smartphones as a result of the grant we have with TAVI, but we're also hooking them up with the governmental smartphones they have now. And if those of you are not taking advantage of this, we've moved away from the flip phone from the era of Obama to now you can get smartphones. So really start connecting your people, if you haven't done this, to the governmental smartphones. And there are many subcontractors, some are better than others, that will help and facilitate this access. So we're doing both of those things. And I think it's really important. So with that, all of the individuals that needed it within the Ryan White program, from that vulnerable population, they didn't have cell phones before, they didn't have smartphones, they all have it and they're all connecting with their case managers. Again, you still have to honor the patient and the client and what they say, even though it's an Android-based phone, we can face you, so to speak, as my 94-year-old mother says, I'm going to face you tonight. The reality, at first I thought it was an insult, but now I get it. So when she faces me, I get to see her. Not all clients want to do that. Clients are giving some really decent barriers as to why this is a concern. I don't want them to see my home. I don't want them to see my hair. I haven't put makeup on. I don't like the fact that I'm looking at a camera all the time. So we have to work these things out. But all of the individuals from that vulnerable cohort, the 400, they're all on board and they're all doing it. So again, just defining telehealth, telemedicine, telecase management, and trying to figure out, I think it's a great question. I really wish I had more. I know Michael's been doing a lot more research than we have, but so I'm looking forward to hearing.
Thank you, Paul. So from my perspective, I think I'll answer it in this way. So right now, we are serving about, roughly about 2,300 individuals in our region, in our catchment area. And if you looked at that, those who are exclusively telemedicine, meaning those that we, the first visit's always done in person. So we always do that. So everybody will be seen in person no matter what. But after that, we probably have about somewhere between 300 to 400 folks that are at the telemedicine clinic sites. And so that kind of gives you that particular group. Now, the other answer to that is the hybrid approach. Those who do one or all of the above, when they may do a hybrid with the phone and others, that's when you get even higher percentages. You can go into 75% who may still come in, but they're also using telephone or even using the telehealth link. So it's a pretty good amount. And if you really start looking at a true hybrid modeling, I think you could really see percentages cross over so greatly. And again, all of it means people are engaged. So your folks that you're seeing are still going to show up as an engaged patient. And one last thing, I know we're going to run out of time, but Rachel, I'm going to encourage NASTAD, I'm going to encourage everybody as we look at reaching communities that are not being served effectively and just culturally. I think we must put into the dialogue about geography. And if we don't, we're never going to get, and rural and small communities cut across all ethnic lines. You've got people of all backgrounds, but out of that, like in our area, we have, heavily African-American and Black communities, but we're serving all that community and we're realizing none of them, there's no data to show it. They have health literacy issues, all of the folks in those communities and the rural areas. And I'm going to have to say this, America has not done a good job of addressing rural healthcare. And that's an issue. And I think people need to start adding that to this dialogue. And that's just my statement. Thank you.
One thing I want to add to that, I think it's important for us to understand the reason why I melded digital technology with telehealth is I believe that's the future. I believe that's where we're going. So with people who are low literacy, what we developed is icon-driven digital health, which is important, as you know. So when people are doing things, for example, we have a symptom tracker. We got that from our consumers that said, we're really embarrassed to go to the doctor and talk to them about our healthcare. Could you help us with this? So we developed an icon that basically looks like a human body. And all they need to do is press on the areas where there's pain, for example. They can show this to their doctor. And then there's a narrative where they can go on a quest to try to really help have a discussion with their doctor. So I think that's such a critical aspect, Michael, that when we're looking at low literacy populations, even access to telemedicine and telehealth and telecase, it may be totally overwhelming for them to queue through all the nuances, whether they're speaking a different language, whether they can't read. So icon development, I think, is a really important way to go. And we insisted on that from the get-go with our digital health. But I believe digital health and all of the tele components we're speaking about are intimately related. And the future is really going towards this aspect of melding the two in a way that makes sense. So just feel that's important.
Great. Thank you all so much, both Paul and Michael, for providing your perspective and for really, centering how we create these approaches to be client-centered, as well as how we can use these various approaches to really, do more work to reach folks who have been traditionally underserved. So I appreciate both of you providing your perspective and also for allowing us to have this fantastic conversation this morning. Next, we will transition to the beginning of our breakout sessions, which will start at 2:15 Eastern Standard Time if you're on the East Coast. Just a couple reminders is we're asking folks in the audience today to please take a few moments to complete the meeting evaluation. Your feedback is important to us and it helps to inform future meetings. You can find a link to the meeting evaluation in the virtual platform navigation menu when you logged into the platform event Mobi. As an added bonus, when you complete the evaluation, on the thank you page, there will be a link to enter yourself into a raffle to win a free FREE iPad Air. So I would highly encourage people to take advantage of that. And then we will select the raffle winner on December 20th. And unfortunately, only attendees who work in health departments are eligible to win the raffle for the iPad. So all of our federal partners, we are sorry, but we still love you. So lastly, I will leave you with one of my favorite proverbs, which is, if you want to go quickly, go alone. If you want to go far, go together. I hope that we can use this time to learn from each other and continue this vital work. And we at NASTAD look forward to being in community with you all over the course of the next few days. And we hope that you enjoy the remainder of the meeting. Thank you all so much. And thank you again to Paul and Michael, and also to both Stephen and Jennifer Lee.